Well, once again, it's time for the Got-IT Talks. With me today is, of course, you, Geraldine Fitzpatrick. And thank you for joining me. It's a great pleasure that you actually accepted to join us, or me.
I'm very happy to be here. Looking forward to the conversation, Lars.
Thank you. So if you'll allow me, or rather share with the audience, what do you do and what was your sort of journey into this field of digital health?
So I do have a long scenic route journey, and it includes things like starting off doing social work from school, going and doing nursing and midwifery, and playing various roles there that included being in charge of operating theatres and outpatient departments, and setting up a private midwifery practice as a very radical thing in the times that we did it, motivated by wanting to offer women-centred care. And around this time I was also doing a science degree, also by the scenic route. And we had lived and worked overseas for a couple of years, and going back to Australia and thinking about what next, I decided to go to uni full time and finish off the science degree. And when I went and talked to the dean, he talked about this new brand new informatics program they had starting up. And I somehow got convinced, or it seemed like a good idea at the time, to move the science degree into the informatics degree program. And so I ended up getting an informatics degree. I stayed on and did a PhD at Queensland University in Australia, and very much in a very traditional computer science faculty, did a very people-centered PhD that overlapped more with sociology than with mathematics or engineering. And some of the projects that we're involved in for that work included some telemedicine projects in the 90s, and various other sorts of health-related projects. And I have since, as a postdoc and in my career, and have worked in health informatics areas and tried to bring together the interests in people, technology, and care, both in the more clinical care context, as well as also in the health care, self-care and health promotion areas as well at different times. And in between that, I also worked in industry as a user experience consultant.
Mm-hmm. So,
and I'm now in Austria.
You're now in Austria, moving from Australia to Austria.
By the UK.
As you do.
I said it was the scenic route.
It certainly, yes, indeed. So this is not, I mean, you're right now, as people that have joined will know, can see that you're working with the Technical University of Vienna. Yet it would be sort of wrong to say that you have a technical background. If of course the science degree of it points to a slightly different direction.
I actually do have a computer science degree and a university medal in computer science. So at the time it was called an informatics degree program. So it wasn't science. I moved from the science degree program to the informatics program, which is essentially computer science.
But I would dare to guess that that combination, I mean, the fact that you have taken the scenic route, that it actually adds some extra layers, some extra qualities to what you do now as well. Which is, I mean, focused very much on the user experience and how to integrate that into new design and so on. So what would you then describe in looking on, well, the scenic route before you What are you then focusing on specifically to try to integrate either in the coming years or in a more general sense? What are your key focus areas?
I think in the more general sense, I think you're right that it's combining those areas. And I think coming from having worked on the ground, literally on the ward floor, and with patients and in the complex environment, I understand the complexities of the environment and the trade-offs that need to be made and the various tensions. I also understand the ways in which people who are delivering care are in it usually because they want to make a difference for patients and they don't want technology to get in the road. I mean, they want technology if it's going to be there to enable. And I think that, also taking a concern for the patient's perspectives, reflecting what I've done more generally in computer science, which was, the human computer interaction with a big emphasis on the human, and in the healthcare setting, the big emphasis on the human, both in the clinicians and more particularly the patients and the informal care network, because they often don't get accounted for. So I think what I tend to do in my work is not try to run away from that complexity and rather embrace it, because I think if we don't understand the complex environments for which we're designing technology to sit in, we're not going to design good technologies. They might be good technology in the abstract, but it might not be good technology in actually enabling rather than hindering. And there are just so many research stories about technologies that have got in the road, that have taken away from patient care, that, one of the big causes of burnout, the increasing burnout pre-COVID. I know COVID has contributed significantly to this, but pre-COVID, one of the big contributors to burnout that much of the research has indicated are around issues to do with technology and electronic health records and what pressures they've brought to work. So we embrace complexity. We use a lot of qualitative methods. We use a lot of participatory design approaches, that sort of thing.
Focusing on a clinical setting?
No, not at the moment so much. So it's sort of, like the rhythms and phases of your life. In the past, we have focused on some clinical settings, and we've had trying to count for all of the care network, because people often just talk about doctors and nurses, or just doctors when they talk about records. We've also done some work working with physiotherapists in trying to support physiotherapy at home for people following stroke, so that they can do their rehabilitation at home. Some of the work that we're doing now is more self-care, healthcare promotion. One of my recent PhD students, Francisco Nunes, was looking at Parkinson's disease and people living with Parkinson's, and the very practical strategies that they engage in to handle their Parkinson's and handle the medications and handle maintaining some sort of quality of life. We do a lot of work with older people and care, because that's a big emphasis, and also with mental health promotion as well.
Driven then mostly by by research or by circumstances?
Being very pragmatic as an academic, a lot of the work that we do is driven opportunistically by funding that we're able to get, because we rely on the funding to be able to resource the research projects, to get access to participants and so on. And you do, of course, have the role in shaping the research proposal that goes in for the funding application. So it is sort of pragmatic in that sense.
Yeah, I suppose there's a rich discussion to be had about funding research as well.
Indeed.
But, we can try to steer away from that one for a while. But focusing mostly then, I suppose, on the current situation as well, and funds for research. The situation that we're in right now is one where, of course, it seems that at least a lot of people, but also some large institutions have discovered an increased need for solutions, digital solutions, solutions to support mental health, telemedicine. There's a lot of things that are what you've just mentioned that that have definitely not lost focus in the last 60 or 18 months or so.
Yeah.
So business is booming. Maybe
business is booming. And if I can take the telemedicine as an example, I think what the last 16, 18 months, 2 years has illustrated as well is it's not a technology problem. It's a social, technical, organizational, professional, financial, legislative policy problem. And telemedicine, you know, as I said, we were doing telemedicine projects in the 1990s, you know, trying to connect intensive care units together to stop patients always being transported to the big city. So the technology has been there sitting on the desktop since the 1990s. And in fact, you know, the research points to video conferencing technology being around even, you know, decades earlier, not as easily accessible though. And the figures for uptake of telemedicine services were sitting at around 1-2% in many countries like Australia and the US, at least in studies that I've read. And over the period of COVID that we've had, those same countries are reporting telemedicine consultations in the rate of about 30, 33, 35%. And the technology's been the same. And what the pandemic situation has done is created this forcing function where, I can't remember who said it, but they talked about, you know, it often takes a crisis for us to realize the technologies we have lying around have value, or working out how to put them to work. And I think people were forced to overcome a lot of the barriers, problems, and tensions, you know, which are often around who funds telemedicine consultations. You know, the new practices that you need to develop both as a clinician and a patient for how do you consult over telemedicine, for gaining insights into what sorts of conditions are better treated over telemedicine versus not, and what information can we get and can't we get, and so on. So I think that, yeah, there's some of the experiences recently have really highlighted the importance of technology. And if we think of homeschooling as well with telemedicine, because it's just a technology. It's the telemedicine, teleconferencing. Teleconferencing is just an application, a piece of technology that can be put to different purposes. And we've now, you know, I think there'd been some step change in people's familiarity with engaging in these sorts of discussions over video mediums. So I think that it's much bigger than just a technology problem. And that's been, I think, one of the big critiques of a lot of technology development and research work in the healthcare space, is that it's often very much framed in terms of the technology and not the context in which the technology gets put to work and all the work that's involved to put it to work.
Yes. In some ways, from people working with pandemic preparedness, for instance, they would probably argue that this was an incident waiting to happen. It's just a natural function of biology, evolution. Something comes along, and if there's a chance for it to exploit our weaknesses, it will. But from another perspective, then from a technological, is this then one of those incidents that needs to happen from time to time? I mean, could Could we, is this the nature sort of also of uptake? Or were we actually designing poorly, or were we designing as well as we could, waiting for the right circumstances that would trigger?
That's a good question, because I'm thinking about our university and the very rapid shift to all teaching being done online. And if I think about our university, and if that had been a proactive strategic decision to do that without the pandemic, it probably would have taken 4 or 5 years of consultations and detailed plans and some little pilots and trials. And I wonder what we can learn from this experience about just getting in and having a go. And because we learn by doing and reflecting and iterate and develop the practices around it, because I think that if we continue to have the mindset of we have to have the perfect plan in place first, we're not going to get anywhere, because we're never going to have the perfect plan. And these technologies, you know, they're not neutral. They have impacts. They change work practices. They change clinical practices. They change possibilities for care. And we often only explore them through the experiences of trying them out. So it's, maybe the question is, what are the minimal set of things that need to be in place, and then rolling out quickly and building in cycles of reflection and iteration. And you know, what does that mean?
I was reminded, I mean, if we were talking about fire safety, you would have fire drills, even though there's no fire. Well, which is a nice way of actually practicing without having the disaster looming. But we could have had digital drills instead before. Maybe we could sort of think about having, I mean, going forward, using that mindset from time to time and say, well, this week we are doing something different, because we're testing our ability to do things differently. We don't know when we will have a fire, or we don't know when we will have the next lockdown, but there's a risk that it will happen. So therefore we are practicing our skills on doing things differently. But as you say, there's also there's a culture here, and it's not necessarily a technological thing, it's a cultural thing. So there's also probably some other elements. It's just, I mean, we focus on digital evolution, innovation, gizmos. But these gizmos, they need to be used by someone. Are we as good as we are in the technological innovation? Are we as good to innovate our training, teaching?
Yeah, I think that there are some moves where, you know, there's in some sectors there's a lot of emphasis on service design, whether technology might be part of it. And I know that that's happening within healthcare contexts. And I think this is on what's the service we're offering. And then thinking, you know, like technology will have a role in that, but it might also involve, I don't know, moving the cupboard to a different place, or putting some sticky signs on the cement path, you know, to help people find their way. I don't know, there could be lots of more holistic solutions. I'm less hopeful, or not hopeful, that sounds, I think there's a longer path to go in terms of our training of people, if we think about students in universities, because we still tend to very much have siloed disciplinary type education models. So you register as a computer science or an informatics student, and that's what you do. And you may be, depending on your program, you may be able to pick 1 or 2 other courses from outside of your discipline, but they're not integrated in a way of thinking and, you know, looking at how you bring these different perspectives together. So I think that we need to maybe rethink some of our educational models and who it is we're training and what mix of skills people need. And I think that will take time, and maybe it might start to happen more at the master's level rather than the undergraduate level. Maybe it's important that people do have a solid single disciplinary base to work from and then develop some other areas of expertise.
I think maybe our viewers will be able to spot that I'm nudging our conversation slightly into the area of or the qualities of interdisciplinarity in digital development. But
it's so important.
Yes, but this is a two-pronged question. In many digital development ecosystems, I've been told by other of our Got-IT Talks experts that, of course, there's a key element of interdisciplinarity that needs to take place, that needs to happen. But what you mentioned here is also that maybe we could actually also introduce some level of interdisciplinarity before people are actually trained as anything particular. So it's not just a matter of thinking of mixing different experts. It's about redefining the role maybe of expertise so that it, I mean, I'm given your background of a dual expertise.
I know, and I also have a master's degree in positive psychology as well to add to the mix, and I so appreciate my own lived and so my different academic strands as well as my work experience strands, and I so appreciate that I have all those together, and I often don't know, I have thoughts, ideas, or contributions I can make, and I know that they're contributed to from all of those different directions, and it's really invaluable. So, and I've always thought of myself as some sort of bridge person who can mediate between, because I do have a formal computer science degree. I can program I did program when I needed to, but not with any passion or joy, except when I was finished. But I know I understand the language of the different communities. So I think someone like me, I can play an important bridging role or translation role between. And I think that there are, so I think there are roles, of course, I would think there are roles for bridge type people. And I also think there are roles for people who sit more firmly within an area, but at the edge. So I would put myself sort of straddling areas. And I think we also need other people who consider the edges where, they're going to be the ones who can much more strongly address, from their disciplinary perspective, I don't know, the security issues or privacy issues of technology that we might be using, or the accuracy of the AI algorithms we might be using in our smart home systems for caring for older people. So I want them there, and I want them sitting close to the edge so that they've got a view out to say, and I know that I need to talk to people who understand people, or I know that people who bring a design perspective have a lot to offer. That's something that isn't one of my strengths, in more of the aesthetic or creative design of tangible artifacts or interfaces. So I think it's recognizing there's different sorts of contributions we need. I think the worst is when everyone just sits in the deep heart of their disciplinary areas and doesn't know how to talk across, or doesn't even realize that there are other disciplines to talk to.
So, I mean, of course, you've been involved in various development processes yourself, but studied other development processes or the process of others too. So is that one of the things that actually more often, I mean, from time to time when things, I mean, I guess you've studied things that work well. You've also studied things that worked less well. But is that then often the case that people get lost in translation?
I think people do. I had a wonderful PhD student who's a lecturer at FR Hagenberg, Jean Hallowell, and for her studies, she was looking at these projects that fall under the AAL umbrella, the active and assistive living umbrella, and she looked at some projects that had finished. So she was looking retrospectively at their documentation and interviewing people, and she was also doing more participatory observation in an ongoing project. And what was really interesting in those projects, particularly in the one where she was part of the ongoing development, was the very good intentions of the people who were running the project, who really wanted to create a system to help care for older people at home on their own and to stop them going into care. And how they started off with trying to get rich understandings of older people and telling stories about their own grandparents, but how very quickly in the development process, in trying to deal with sensor-based technologies, people got reduced to the action of opening a window, blind or something that would indicate that they're up. So they got reduced to sensible, actions that technology could sense. And one of the things she identified was the way in which they lost the heart of the real people, as whole people in that context. So there's lots of challenges, and good intentions aren't enough.
No, but obviously in most development processes, there's probably a budget involved too.
Yes, indeed. Yeah.
Yet, if you spend €100 and the thing doesn't work, you've lost your €100. So sometimes spending €200 and actually get a thing that works would probably be a better investment. Is this then also maybe thinking from a technological point of view, we can be amazed by things that would be in a technical sense possible, but we're failing to recognize sometimes that when we're humans, things that are technically possible is not the same as them being culturally possible, not tomorrow anyway.
Or what are they leaving out? Because one of the things that many of the smart home systems do is inadvertently or subconsciously prioritize the needs of the healthcare delivery service, who are trying to, rightly, because they have real needs, manage their limited budgets, resources, and with our aging population can't deal with all of the people going into hospitals or aged care homes in the way that we did previously. And so if you can install some smart technologies in the home or the room that might track movements, that might detect people falling over, it can be a tick in the box for them, that it can help recognize when an incident happens at home and get care to the person in a timely way, which will be cheaper than having them in hospital or in a care home. Except what that does is frame the person as a problem to be solved, and frames well-being as the absence of falls. And what it misses is the richness of, older people are people too, and want to feel loved and needed and connected in different ways, and feeling like they contribute. And so we're missing a lot of what are the really important quality of life things. And there's so much research, for example, that talks about the importance of social connections for older people health and well-being, with much bigger impacts than just sort of, a fall or not, in terms of more general population. But again, good intentions, like we need, the healthcare system has real needs, but some is just different voices have more power in the process.
Yeah. But if you were one of those people in power, and were to decide a new, I don't know, how many should we mention today? Three good policies that you would like to see implemented tomorrow to help shape a better process, maybe. Of course, if you had all the money and power in the world, you would just design perfect systems. That's obviously, but what would be some of the elements that would, at least in our imperfect world, help guide us to better solutions?
This is always tough because it's very easy to be the critic at the edge, isn't it? And if I was in power, I think I'd want to make sure that there was always a critical friend voice involved in the process. When we do, in many countries now, when you do big infrastructure projects, you have to do an environmental impact statement. And I'd love to see something implemented in our technology projects, especially around care, about, I don't know, what we would call it, people impact statements or values impact statements or quality of life impact. I don't know, but something that reflects on what might be some of the, the positive and negative consequences for this. I would also want to have processes built in from the beginning to try to identify multiple stakeholders in the process. And, I've mentioned the healthcare system that the governmental systems that need to fund these applications in the public sector anyway. And we've talked about the patients and we've talked about the clinicians, often just in terms of doctors and nurses, but I think we also need a much richer understanding of the stakeholder network, because it is the informal carers, maybe other people living in the home or extended family members, or there may be community-based organizations. And I'd like to see more mapping done at the beginning of a project, maybe tied in with this impact statement, like stakeholder impact. Maybe it's stakeholder impact statements. I'd like to see some better stakeholder mapping and try to understand how decisions might impact all those different relevant stakeholders. So there too, and I would love us not to have the model of technology thrown over the wall, end of the project, but rather really built in assumptions that we're going to get it wrong. Or that we're not going to get it totally right would be the better way of putting it. And so building in what are those review and what are learning points, so we can learn what's happening, we can iterate, and whether that's iterating on the technology or iterating on a work practice. Because as part of that deployment, I think we also need to think about redesigning the work practices involved.
That, which is I guess maybe it's just a personal fascination, but what would constitute for you a framework or an idea that would allow I guess a more a slower expectation or a more patient, not patient-oriented, but patient approach to implementation. I mean, it, as you say, of technology being thrown over the wall. At times, it seems that we tend to assume that if it can be turned on and off, that is all that it needs, and people will figure that out, and then we can just leave them to it. In practice, you see hospitals, you see nursing homes, you see offices, you see all kinds of places in our digital world where rooms are filled to the brink with technology that was bought with all good intentions and left there to rot.
Yes, indeed. Yeah. Indeed. And it's the equivalent is the laptop in every classroom, promised from politicians. And there is a laptop in every classroom and it's sitting down the back unused because teachers don't know what to do with it. or don't have content to use on it. I do want to caveat, though, that there are very different considerations if we're looking at, I don't know, an app on a smartphone for me managing my own health and well-being in some way, tracking my activity levels or things like that, to something that may be like a smart home installation, to a national infrastructure for electronic health records. Because the scale of complexity just blows out. And what's fascinating, though, is we still have trouble getting these app design of these, what we think should be the much simpler applications right. Where it's just a person interacting with their own data without any clinicians involved. So that I do want to caveat, I do want to recognize that there are all those complexities. And in having put forward that caveat, I've now forgotten what your question was.
My main question now, I suppose, was how we might actually then have a process where we could actually recognize that complexity. If it's so hard to get people to use an app, obviously it will be harder to get them to use something more complex. But if we allow people the framework somehow of better training, better education, better support. I'm struggling, of course, because I do statement.
I think that your question also talked about technology in cupboards that's not used, and I'm reminded of a lovely paper in the Trials Journal, and this is where people publish their study design for their randomized control trial. And this was a few years ago, and it was in a UK health authority, and they were planning one of these smart home installations that had more things like smoke detectors and fall detectors and little collection of devices. And they had their lovely randomized control trials design plan, in most of the paper. And just at the end, they sort of said, as a by the way, that all of these technologies had basically been sitting in boxes in their warehouse for the last year, because what they realized was, if they want to run this project, they needed whole new negotiations and partnerships between local government levels and the National Health Department. They needed new roles. They needed people taking on new roles, like who was going to install it, who was going to troubleshoot it when things went wrong. They had to create a whole lot of policy documents. They had to work out who was going to be responsible for which bits and what were the communication flows. They had to have a monitoring center set up. And so there was just so much involved. And this is where I think that mapping out the context and the stakeholders involved in putting the technology to work will start to perhaps uncover different values, priorities, concerns, and just seeing what tensions or whatever need to be negotiated, identify what new work practices need to be put in place. So I think that work needs to be done straight up from the very beginning. And then when the technologies are out there being used, building in, employing people who will go and observe, interview, talk to people to understand where it's breaking down. And again, just an example with Tariq Anderson and colleagues in Denmark, in Copenhagen, where you are, they had a lovely project with implantable cardiac devices, which produced all sorts of lovely data that would automatically wirelessly transfer up to the consultant doctors, as the patients had went past some unit in their home. But what they found was the consultant cardiologists didn't know how to make sense of the data. They could see that a heart rate was high or that something had happened with the heart rate figures, but they didn't know, they couldn't interpret it. And in their iteration of the project, they ended up creating a web interface, My Record or something like that, where the patients could say, I know my heart rate was up there, but don't worry, I had just walked up the stairs. Or I know my heart rate looks good here, but I actually felt terrible. And there was much richer information. And, like a small insight led to a small innovation, adding in this web interface that really made the data being collected valuable and enhanced the patient-clinician relationship and treatment of their cardiac disease.
Some of the digital developers would, I mean, before, as you say, there's a difference between an app and a national solution of some kind. Next week in the Got-IT Talks, we'll be talking to Therese from Sundhed.dk, which is, of course, a national entity that works with the huge solutions, Corona passport solutions and so on, which is, of course, massive in terms of complexity and so on. But for a lot of those digital developers that are doing the apps, they're often a smaller size operation. And for them, some of the things that we've been talking about so far might be a little bit daunting. But what can they? I mean, what's it's studying the works of the greats. Should they should they pack up and go home? I mean, because it's actually the complexity is too daunting. I mean, what?
Yeah.
Then also maybe some key advice for the smaller digital developer to get off on a right track.
I think that there's a role for multidisciplinary teams while we're waiting to get more interdisciplinary people. And so if you're a developer, have someone who's a domain expert on your team somehow, and or have a user experience consultant or a person on your team, someone who can take a concern for those issues. These sorts of factors can make or break apps. One of the big reasons that's reported in why many of the behavior change health and well-being apps that often have a behavior change focus don't work is that they don't understand the science of behavior change. And that doesn't necessarily mean going out and getting a psychology degree in behavior change, but there are guidelines that exist. There's a good group in London who I can't think of right now who have operationalized lots of psychology strategies for behavior change that have implications for, suggestions for what you might think about. I think that it's that identifying in the mini stakeholder sense, I guess, what are the elements we need to do in this app. So it's not just that we need a database and data and we need security and we need to take a concern for privacy, but what's our engagement strategy? How do we keep people coming back to the app? Because it's repeated use that matters. What's our motivation strategy? And how do we recognize that different people are motivated by different things? And what personalization options do they have so they can go, that's me. So I personally, I might use a running app, but I hate it when I get the yay, Jerry, you just got your record thing, and I got one on Sunday because I'd forgotten to turn off my Runtastic app that was tracking my cycling when we took the bikes on the train to come back home. And, so I suddenly got a kudos for my 1 minute kilometer cycle. So so those sort of things don't do anything for me. I would turn them off if I had a choice. And I probably do. I haven't looked at it. So we need to understand all of those use aspects as well. And one of my PhD students now, Francisca Tashler, is looking at unaccompanied migrant youth and mental health promotion. And you might say that there are loads of apps that currently do mental health promotion, some aimed to youth, and why don't they just pick those up and use them? But what she found by talking to these youth was they often live in quite unsatisfactory shared accommodation environments. And so they don't want an app pinging them at 11 o'clock at night, telling them to go to bed, or giving them some cutesy message when other people are around, because it's not culturally acceptable to be doing this, and something they would want to keep private. And that's something that if it's just me using it in my home, it's not an issue to be thought of. So there are lots of subtle issues that can make or break an app.
If you'll allow, I mean, there's some designing digital solutions for disadvantaged groups is definitely something that's very worthwhile. And if we can agree to come back to that point a little in a short while, luckily most of our users are not in those disadvantaged groups. Yet one of the challenges still of getting an uptake in some of the regular groups of people would be the interaction between them and their healthcare provider, service provider, GP, nurse, physiotherapist, and so on.
Yeah.
And these wonderful and great healthcare professionals, they are of course not, well, technicians. They have trained for something else, something different.
Yes.
Yes. What's and we're introducing an awful lot of digital,
absolutely,
digital possibilities,
yes,
for people. But it seems maybe, and you mentioned the stakeholder mapping, and one of the things that you did mention in the stakeholder mapping was, of course, healthcare professionals. But as much as we are designing and we're using the app as a case here, designing the app for a wonderful user experience for them when they are sitting in their home or on the train, whatever. It seems a little bit that the user experience that we're designing for those healthcare professionals is not as appealing right now.
No. And that's one of the big reasons why,
you mentioned
a couple of the big reasons why, healthcare professionals aren't recommending apps. And there are, over 300,000 health-related apps on the app stores, and that's a figure from a few years ago, so to be more. They don't know what to recommend in the first place. So what's based on sound clinical guidance and good design principles. But then if someone does come with an app to them, there's this mountain of data, and in many healthcare systems, people are time boxed in how much time they get funded to spend with patients. There's an implication of medico-legal responsibility that if I've had the data in front of me and there was something in the data that I missed, I can be sued. So there's a big fear about that. And then there's the lack of skills about how do I make sense of this mess of data. I think we're going to be heading to a new role that's an intermediary role. And this was something that some colleagues, we wrote up in a paper following a workshop where we discussed these issues. And that was a couple of years ago. So we talked in that paper about someone who would be the informatician role. So I might come to my doctor's surgery with my app with all the data, and I first of all see the informatician, and they download the data and do some graphical visualization or some statistical analysis on it, and provides the more readable, interpretable graph data for the clinician to then look at. And so I think we are going to be heading to those sorts of roles. We haven't, and this is the thing about trying to map all of the stakeholders, we often just think about the patients, and we forget the clinicians who also have to deal with this data. So yeah, it's a big issue. And again, in Denmark, there was a lovely project. Well, it was a European project called Manaka, where they were dealing with bipolar depression. They had a very good participatory design process with, you know, the psychiatrists, the nurses, the patients, family members sitting around tables designing every aspect of the system. And when they deployed it, there's a lovely report about the ways in which the nurses, who were the gatekeepers looking at the dashboards, so they would log in every morning and see all the patients who were using this app, and that they had a real struggle with how to manage that new information, because a quote that Mads Frost reported in a paper in his thesis was, you know, normally I'd pull these people out of a drawer once every 6 months, and now I see them every day. So there's a different granularity of insight into people's lives and into people's conditions. And then they had questions: if they started to see someone trending upwards on a Friday afternoon, what do I do with that information? Do I phone them? Do I have to come back into work at the weekend because I'm worried about them? You know, took them a long time to work out how to make sense of this new information. And that wasn't so much the visualization, but the responsibility of having that data. So yeah, it's complex.
The informatician. Is that something then that, as you say, you think we will see? Is it something that we will see in the space of a few years? Are we talking about a decade? What's the time scale here?
I haven't thought about that.
I'm not. I won't be following up later.
I haven't thought about that. It's maybe because I think we're producing people who have those skills. I know that there's a great group within our institute and our faculty that looks at information visualization and has a lot of expertise in medical data. So someone who came out of their group would perfectly slot into this sort of role, except there's no label for that role. So I think, and we also have some very good graphical design interface people who may be able to provide the work of the tools to create, you know, understandable visualizations. So maybe, I'm thinking out loud, maybe we have the people with the skills that we're producing, we just haven't identified the role label as a system,
maybe yes,
into which we employ them.
But thinking one of the other European projects that's ongoing at this point is, of course, the TATUS project, the Joint Action on the European Health Data Space, where among it, well, it's a huge project, but among the challenges in that project is, of course, how to get people to, well, we're not talking about persuading anyone. I mean, it's just about how do we bridge here? How do we find a path forward that would allow us to bridge these different stakeholders into a new type of format or understanding? But it's interesting, though, that in that we have a predefined set of assumptions as to these different stakeholders, and assuming in a way that the type of stakeholders will be fixed, permanent, ongoing. And what you're introducing here is, of course, that maybe we actually also should invent new types of people, a new type of stakeholder entirely, which is an interesting.
In the way that we've done with the call centers or the monitoring centers for the smart home installations. You know, they didn't necessarily exist before, but now they exist.
Interesting. Yeah. Well, some interesting facts on how to bridge on and how to connect interdisciplinarity and multidisciplinarity, and how to actually get some good ideas at a system level and on an individual level. It was great talking to you, Jerry.
Thank you,
and
Lars.
and sharing a bit of your scenic route with us. And I look forward to talk to you again sometime in the future on the future of digital development.